So my name's Carolyn Hullock. I'm an emergency physician. I work at, mostly of my clinical work at the moment is at Belmont Hospital, and for the people in New South Wales, it actually has one of the oldest patient populations of emergency departments in New South Wales. So we regularly see people who are aged 100. I'm also on the executive of the Geriatric Emergency Medicine Special Interest Group for the College of Emergency Medicine. And it's really good for me to be part of that group because people from Australia and New Zealand who are interested in the same things as me get together to talk. So maybe I should have called it Michael, but I think regularly in emergency departments, and if you ask emergency department staff, and you ask them about delirium, they talk about a patient like Mrs. Rosen. So she lives alone. She came to the emergency department 3 weeks before. She'd fractured her arm. She'd spent a couple of days in hospital and then gone to a rehab facility. The facility staff at 8 o'clock on a Friday night sent her back to the emergency department because she was in pain, she was distressed at night and wasn't cooperating with the rehab program, and asked the emergency department to sort it out. So she spent about an hour or two in the emergency department, and then a nurse comes along to you as the senior doctor and says, you have to do something about the patient, she's trying to climb out of bed. So I think, and by that stage, she's so agitated that there's really not much other choice than to sedate the patient. So we need to do better than that. Is that right? So the emergency department is, if you think about all the things we've spoken about this morning, is just not a good place for delirium management or prevention. It's made and designed for acutely unwell, fit and healthy men. It's a military kind of model of care, and can I say that? It's noisy, it's bright, 24 hours a day. There's patients are moved from one spot to another regularly. We often don't have the family around. There's limited access to food, there's limited access to water, there's limited access to toilets. We put cannulas in people, we put catheters in people, and we're also in an interesting place at the moment where we're asking for patients to only stay in the ED for 4 hours, which has its advantages and disadvantages, but means that patients are being shuffled around a lot. And I suppose one of the other important things is the ambulance and the emergency department, as Joan referred to, tend not to prioritise older people. So we need to kind of rethink all that. And these are some of the things that we've been working on in our emergency department. I was actually pretty pleased when I read the standing because I think we've covered them all, so that's good. So in Newcastle, we've got a program called the Aged Care Emergency Program, which is now covering about 100 aged care facilities across Hunter, New England, and all the acute facilities and some of the smaller rural hospitals as well. It involves about 20 algorithms for common acutely unwell symptoms for patients living in aged care facilities. And it's around empowering and supporting the aged care facility staff to manage the patients themselves. But we also have a 24-hour nurse line where they can ring in and get advice if they need support from someone who has a different set of skills to them. And it's in partnership with Hunter Primary Care, which is our primary care organisation. So during the day, the ED nurses take the calls, the aged care nurses, and at night time it's taken by the call centre through the Hunter Primary Care. And then if the patients do need to come to hospital, there's good clinical handover, but importantly there's also really clear goals on why is the patient coming to hospital, because often when we get a really complicated, complex older person from an aged care facility, it's very difficult for the ED staff to actually know what we need to do. And our most recent evaluation, patients who went through this program were 40% less likely to be admitted to hospital. The second one, Joan will like, which is around family and patients being together. So we did a lot of interviews with older patients in the ED and their families, and I suppose the big message to me was around patients and families being together. Interestingly, my sister is 48 and she had her tonsils out 45 years ago, and my memory of her being in hospital was families and patients being separated and her being, you know, we were allowed to visit her between, I don't know, whatever time it was, 10 and 12 at the age of 4 or 5, and it was a pretty terrifying experience for her. And I actually hope one day into the future families of everybody will be together in hospitals and not separated. I think the other thing to remember though that I learnt from this, these interviews were often the carers are very old themselves. So if the patient's 95, then their partner's probably 95 or 94, and they often sit with them in the ED. So we're kind of at risk of not only having the patient delirious, but also the carers delirious as well. They're often exhausted, and they've often been have minimal supports at home, and things might have been going on for weeks. So I think we have to also be mindful of looking after the carers and not thinking that they have to be with the patient all the time. Just a opposite side of the story, I think. New South Wales, we have an aged services emergency team. So we have a nurse in the emergency department who's responsible for older people, who is the advocate and champion for older people. They're involved a lot with discharge planning, particularly complex patients who are going home, and knowing what services can be accessed. They coordinate the care and they do a lot of the screening. So we're actually really lucky to have those staff. And in our EDs, they work 7 days a week. Delirium screening and referral, we've talked a little bit about. So just the practical way it works in our ED is that when the triage nurse triages the patients, if they're over 75, not 65, but older, we just put the sticker in the notes because we've still got paper. Just so then the next clinical staff, whether it's a nurse or doctor, can then fill out the delirium screening. We did a trial at John Hunter using older person technical assistant. So it was a technical assistant, so not a clinician, who we actually trained in some of the screening tools. We can debate about that for a while if you like. But their role was really to work with the nurse, to support the nurse to better manage the patient. So they did a lot of delirium prevention. They were feeding patients, looking after families, making sure families and patients got fed, sitting with them if they were agitated. So it was a really important initiative, I think. Didn't get funded, but anyway. The last one is the clinical pharmacist. So again, some emergency departments have pharmacists, some don't, but often these patients are on multiple medications. And we again found when the clinical pharmacist saw the patient in the ED, they were much less likely to be admitted to hospital. So another important part of the team. But I think the good thing for me around the development of the standards is that it will make other people who aren't in this room, clinicians and managers, realise that delirium is actually important and we need to do something about it. So thanks for allowing me to talk today.
Before you rush off, I just wanted to ask you, what are some of the challenges, you touched on it a little bit, but some of the challenges of identifying people who come into the emergency department that they have delirium? What are some of the challenges you face in that fast-paced environment when they might be missed for the more acute patients?
I think the problem is that the patients are often there by themselves. So knowing whether their behaviour is their normal behaviour or it's a change from normal is actually one of the big problems. I think every subspecialty in medicine has a group of patients that need to be seen urgently, so the trauma patients or the AMI patients or the urinary retention patients. So it's actually trying to develop something that's actually urgent and important for older people, I think, so that we can actually make sure that we see them sooner rather than later.
And you touched on it a little bit, but what do you think are going to be the main ways that these standards will help patients in the future?
Oh, I think the most important thing is it's make a strong message that it's important.
Putting it as a priority. Mm-hmm. That's great. I'm sure most of the people in this room would agree with you. So everyone thank Carolyn for her talk. Thank you.